Hello everyone, my name is Orbán Sándor, and let's have some new insights on the treatment of metastatic gastroenteropancreatic neuroendocrine tumors. So, after the first few glances in our research, we believe that systemic radioligand therapies are not entirely optimal for metastatic gastroenteropancreatic neuroendocrine tumors, because still 31% of the patients die within 5 years. This systematic review and meta-analysis provides clear evidence that primary tumor resection before radioligand therapy significantly elevates the survival rates by 47%. Therefore, primary tumor resection should be considered before radioligand therapy for these patients. However, since only observational studies are available, randomized controlled trials are crucially needed to elevate the evidence level. In addition, specific patient populations need to be identified who could benefit from this operation. Policymakers should allocate research fundings for these initiatives. So I'm a first-year PhD student and a medical doctor, and my vision is to advance the treatment of gastroenteropancreatic neuroendocrine tumors, improving survival and quality of life. And my mission is to find the best combination and sequence of treatment modalities for these patients. I have two ongoing projects. The first one will be conducted via meta-analysis, and the second one via SEER Registry Analysis. Neuroendocrine tumors are rare malignancies rising in incidence and prevalence. Most of the patients will be metastatic already at the presentation. Metastatic disease is a systematic disease. It requires systemic medical treatment. However, recent clinical studies suggest that in metastatic GEP-NET patients, removal of the primary tumor could prolong survival. So the first project is investigating the effect of primary tumor resection prior to PRRT in metastatic GEP-NET patients. Most of the GEP-NETs exhibit somatostatin receptor overexpression, which can be targeted by somatostatin analogs or with radioligand therapy. Some studies suggest that lower tumor burden is associated with better response to radioligand therapy. So the question arises, is there a potential benefit of primary tumor resection before PRRT? The main population we are investigating is stage 4 GEP-NET patients undergoing primary tumor resection plus PRRT versus PRRT alone. And the main outcomes we are looking for are progression-free survival and overall survival. And our hypothesis is that primary tumor resection prior to PRRT improves prognosis in stage 4 GEP-NET. Here you can see the search key we use for the systematic search, the first domain being about the population, the second one about the intervention. Here you can see the flowchart of selections. At first we had around 7,000 articles, but now we are down to 20. Here you can see the first forest plot in which we were looking for, the outcome we were looking for was a progression-free survival, which is an important oncological outcome defined by the length of time in which the patient's disease doesn't progress after therapy. It was measured by hazard ratio. Hazard ratio below 1 means better progression-free survival with the combined therapy. Above 1 means better progression-free survival with the PRRT alone. So we had 7 different populations from 4 different articles with around 900 patients with the moderate heterogeneity, which can be explained by the different primary tumor sites, grades, and different pre-treatments. The pooled hazard ratio was 0.66, which means that patients undergoing combined therapy have 34% better chance for progression-free survival. This finding is clinically relevant, statistically significant. The second outcome we were looking for was overall survival, which is also an important oncological outcome. Here we had 6 different populations from 3 different articles with around 800 patients with moderate heterogeneity, which can be due to the different primary sites, grades, and pretreatment, and the pooled hazard ratio was 0.43, which means that 57 better chance for the combined group for overall survival. This finding is clinically highly relevant and statistically significant. The strengths of our studies are until now there have been no summarized information available concerning primary tumor resection prior to pre-RRT. We have conclusive, clear, clinically relevant results. It was conducted via a robust methodology, and the limitations could be the few available studies and most of them being retrospectives in nature. So our conclusion is that primary tumor resection before PRRT provides a clear survival advantage. It should be considered for well-selected stage 4 GEP-NET patients, and the implication for research is that prospective randomized clinical trials are crucially needed with subgroup analysis for different primary tumor sites and grades with standardized quality of life assessment. So the first project progress, we are currently doing parallelly the grade assessment and the manuscript writing, and we plan to submit the manuscript in the first part of July. So the second project is investigating the safety and effectiveness of surgical excision of primary tumor in well-differentiated metastatic pancreas neuroendocrine tumors. PNETs are rare neoplans which account 1% by incidence and 10% by prevalence of all pancreatic cancers. So the question also arises, is there a potential benefit for primary tumor resection in well-differentiated PNET patients? The population we were investigating was grade 1-2 metastatic pancreas neuroendocrine tumor patients undergoing surgical excision of the primary tumor or ablation of the primary tumor versus systemic treatment only, and the main outcome we were looking for is overall survival. Our hypothesis is that in patients with metastatic well-differentiated PNET, surgical removal of the primary tumor improves overall survival and disease control compared to medical therapies. The clinical implication could be improved patient outcome, survival, or even cure of the disease. It will be conducted via SEER Registry Analysis. The SEER Registry is maintained by the National Cancer Institute. It provides data on cancer incidence, prevalence, survival, and mortality. We gained access to it through the SEERStat application, and currently we have more than 2,000 patients selected in the intervention group. So as a summary, the first project is currently at the manuscript writing phase, and we plan to submit it in July this year. The second project is at the patient selection phase, and we will plan to submit it next year, June. And let me finish my presentation with the words of Carl Sagan: somewhere something incredible is waiting to be known. Thank you for your attention.
In your first project, do you have data that the localization of the primary tumor, does it affect in the decision for surgery or not?
Yeah. Until now, the indication for surgery, even in metastatic disease, was if it can cause obstruction, it bleeds, or it produces hormones. Now, for a small intestinal neuroendocrine tumors, it is regular to have to operate them because sooner or later it will cause obstruction. In our studies, we see that most of the operations was done on small intestinal neuroendocrine tumors, but in results, there is every localization can benefit from the primary tumor resection, which is interesting because we thought also that maybe small intestine will have the best prognosis.
What is the time interval in the SEER registry that you're using?
Thank you very much for your question. Actually, there are multiple different databases in the SEER registry. We plan to use all of them, and we will remove the duplicates. But the latest one, which I currently used, spans from the 70s till the 20 November of, yeah.
And will you differentiate between
different eras?
Years, yes.
Yeah, probably yes, but I'm not sure if we will find many cases in the early years.
So for better outcomes, primary tumor resection seems obvious. But in those studies where the patients were not operated on, what was the reason for that? Why didn't they operate them?
I mean, this is not a guideline decision, so it is currently not recommended by the guidelines to operate primary tumors. But if you mean how did they get in the control group in the articles, very good question. Some of them was inoperable, some of them was multiple primaries, and some of them was unknown primary site.
I see. In your study, why don't you incorporate grade 3?
In the second project, we don't want to incorporate grade 3 because before 2017 it was not that clear the border between neuroendocrine carcinoma and grade 3 neuroendocrine tumors.
Yeah, that's true. Do you just a national study? Do you use the Hungarian national cancer or international, European?
This is actually national data from the US, but I'm not sure if we have data from Hungary. It would be nice to compare them and analyze that also, but unfortunately I'm not sure if we have a neuroendocrine tumor registry.